Welcome to a podcast of the American Academy of Orthopedic Manual Physical Therapists. Today's episode is sponsored by the Foundation for Orthopedic Manual Physical Therapy, which is committed to advocating for excellence in OMPT practice through its funding for initiatives in fellowship training, education, research, and public recognition. The Foundation for Orthopedic Manual Physical Therapy is a 501c3 organization, and all contributions are tax deductible. Donations can be made at our website, aaompt.org/foundation. This podcast series will feature interviews with content experts in manual therapy.
Hi, my name is Skip Gill, and thank you for listening. Joining our show today is Dr. Lori Michener. Dr. Michener is a professor and director of clinical outcomes and research, known as CORE, and the director of the CORE Laboratory in the Division of Biokinesiology and Physical Therapy at the University of Southern California in Los Angeles, California. She is a board-certified clinical specialist in sports physical therapy and sees patients at USC's clinical practice. She earned degrees in athletic training and physical therapy and her PhD in orthopedics and biomechanics from MCP Hahnemann University in Philadelphia, Pennsylvania. The central theme of the Core Lab's funded research is to define optimal treatment pathways for patients with musculoskeletal shoulder disorders by characterizing biomechanical and central mechanisms related to the presence of movement deficits and poor recovery, defining classification and management approaches, and determining optimal outcomes of care. And with that introduction, we'll get started with this episode. Well, it's great to have you here today, Lori. Thank you for joining us.
Thank you for inviting me. I look forward to this.
Our listeners are always interested in the path that leads people to their specialty area. Could you tell me maybe what sparked your interest in the shoulder region?
So I got interested in the shoulder region during my PhD. I went to Hahnemann University in Philadelphia, which is now Drexel University. And my advisor at the time, Phil McClure, was interested in spine conditions, which that was one of the things I was really interested in studying. And he was also somewhat interested in shoulder. And the division there then hired a biomedical engineer, Andy Carduna, who had a strong interest in shoulder, which then moved my PhD advisor, Phil McClure, to studying predominantly shoulder. But I didn't know as much about the shoulder as a clinician, so I took a part-time position at Penn Therapy and Fitness and worked with two excellent clinicians, Marty Kelly and Brian Legan, who had a lot of expertise in the shoulder, and I was fortunate enough to be mentored by them from a clinical standpoint. And so I really rounded out both my interest and hopefully expertise clinically in research in the shoulder region.
Yeah, that's a great pathway, and you've clearly done a lot of great work in this area. Research in several areas of physical therapy indicate that not as many people access a physical therapist as a first line of treatment like we'd expect. So do you think this is a similar challenge to shoulder patients, so to speak? Do you suspect we've got a lot of patients that are accessing higher risk interventions like injections or surgery before they've really had a good course of physical therapy?
Yes, I think the evidence bears out kind of generally across musculoskeletal conditions, and this has been studied a lot, as you know, in low back pain, that accessing medical facilities typically puts them into buckets sometimes of getting these higher risk interventions. And I'd even put these high risk interventions, sometimes imaging in there, in the sense that they're not a risk to the patient's body, but a potential risk to them seeing imaging findings and associating that with something that needs to be fixed, which then leads to potentially surgery.
Right, puts them on a higher risk pathway.
Correct, high risk pathway. That's a great way to say it. And I think one key thing that may be a path forward for us as a profession is being better about advertising to the public how to access. Do you need a referral or not? And the majority of states are direct access without referral. And two, what to expect from physical therapy. I think that when an advertisement is, oh, do you have shoulder pain? Go see a physical therapist. That's just not helpful because
Right.
I want to hear what should I expect. Oh, you have shoulder pain and somebody's told you have a full thickness rotator cuff tear. Well, here's the good news. 80% of patients at 2 years say after about a physical therapy, 2 years later, they don't want surgery. They're happy with their result. People want to know what is the expectation of outcome with a given condition and or body region. Like, what is physical therapy going to do for me? I don't think it's just good enough to say, go see a physical therapist. It's what should I expect?
That's great. And just to circle back on, the part about imaging that was kind of a question I had about having those conversations with patients. If you have someone that comes in maybe with low expectations for PT because they've either had imaging or MRI or they've seen another provider that says, you've got a bad tear or you've got, arthritis and it won't heal. Certainly talking to them about maybe some of the evidence, like you just said, is important. Any other strategies that you kind of use with talking to patients who might come in with a predisposed, low expectation for physical therapy?
Sure. So that takes us a little bit different path from the first question, meaning what can we do better to
Yeah.
the general public? Okay, now you've actually got the person in your office because somebody told them to come there or whatever, but they're still not clear about what to expect. I mentor residents here in our orthopedic and sports residency programs at USC, and I strongly advocate and do it myself in my clinical practice. In that first visit, you have to be clear with the patient about assessing their expectations about outcome from physical therapy, their expectations about what physical therapy is, telling them what your general treatment plan is, how long is it going to be, what is your criteria for when they're getting better or not, and are you going to keep reassessing them to make sure they're on the right path, and what's the prognosis. How that sounds when it comes out of my mouth, and this is how I deliver it to patients, but I think it's helpful. So the patient who's sitting in front of me, okay, we've done the exam and your diagnosis is a full thickness rotator cuff tear. You might have had imaging to suggest this. My findings indicate the same in our clinical exam. Well, here's the great news. Lots of people can do really well with physical therapy. This is what the plan is, and describing the exercise, stretching, etc., that you anticipate you're going to deliver to the patient. So telling them what it is that the treatment will be. And I suspect that you will do well with physical therapy as well. In my experience, you look like a lot of other patients I've seen who have a full thickness rotator cuff tear, and they've done well. And you kind of look like what the evidence tells us that you should likely respond. What do you think about that plan? And that gives them the opportunity to say, well, I hear you and I've tried exercise and it's not gotten better. Is there an opportunity to say, well, you've talked to me about these exercises. I think you might have not been having the right dose, the right type, whatever it is, describing how this program is different than what they may have done before. And do they change their opinion of likely it's going to be helpful or not? Let's assume they say, oh, okay, yes, I agree with that plan. Great, but here's the thing. I'm going to keep reassessing you over the course of treatment. It's not like I'm just going to put you on this plan and then I'll see you in 6 weeks and hope for the best. Every time I see you, I'll keep reassessing to make sure you're right on the right plan. I'm going to keep asking you about the difficulty you're having with your daily activities and make sure that this treatment is moving you in the right direction. Otherwise, we need to change the path.
I appreciate hearing that. I mean, just some very good phrasing and just a very good approach as well. So I hope if we have some junior therapists out there that are listening that are looking for good ways to approach this or good phrases to use, I think those are some great examples of how to talk through these challenging kind of discussions with patients.
And I think as a new therapist, sometimes it's really difficult for them to feel like they can say, well, I've seen a lot of patients that look like you and they've done well. Sometimes it is figuring out what you feel comfortable with. I like to say PT is a sales job in the sense that you are selling this intervention and making sure your patient is buying in. So when I say sales job, I mean creating a good therapeutic alliance for the delivery of the treatment. You're a good person for them to be working with, and they see themselves getting better under your care.
Yep, absolutely. Great. Well, another question I had for you was, I know a lot of your current and your future research is investigating the role of central mechanisms in shoulder pain and shoulder treatment. And I'm wondering how you talk about this concept, maybe with patients or even other healthcare providers. It seems like it's difficult enough to explain this concept, even when we're talking about spine-related conditions. So I wonder, it seems like maybe it's an even more difficult conversation when it's related to a peripheral joint region.
Yeah, I find this challenging myself as well. For example, I've studied a lot of manual therapy plus exercise versus exercise alone. Early on in my career, I would be doing mobilization or manipulation to the thoracic spine and or shoulder. I would, in my early career, say, oh, it's not moving as well and I'm trying to improve the movement. And the evidence really doesn't bear that out in the thoracic spine, that it is not likely a movement deficit and delivering that isn't correcting some of that, but rather it's likely these central mechanistic effects that manipulation is providing. How do I say that? I find it troublesome sometimes, and I hear myself even struggling to figure out how I might say it right now. I will say, listen, so we're going to do some things to your spine because the evidence has kind of bared out that if we do some movement here, this delivers some sensory input to your brain that really can help kind of reset and help your shoulder pain. That's how I might simply say that. Sometimes I feel like it's easier if I just say, "Oh, it feels a little stiff," and I'm making it move better. But that's disingenuous, and also I don't want patients to think, "Oh, I need to get this improving better because this will help my shoulder pain if I'm doing thoracic spine." So I try to be true with what is the most likely explanation about why this is helping.
Yeah. And I think to a certain extent, we would like patients to start realizing that there's multiple effects to our interventions. And it might not be just what we're moving, but how that affects these other systems. I mean, I sometimes do get patients who are very interested in those central mechanisms, those brain connections and things like that. But for other ones, it seems a bit challenging.
Yeah, and a doctoral student, Joe Cardoni, who was a student of mine at VCU and was a military PT,
Yep.
and he looked at the immediate effects of thoracic spine manipulation on shoulder pain and function, thoracic spine mobility, both active and passive, and understanding what is the effect locally at the thoracic spine. And we really saw no effects at the thoracic spine however we evaluated its effects. I've subsequently did a small pilot study here that we have not published yet, but had looked at same cohort, shoulder pain patients, have them come in, evaluate them and their brain imaging and their pain sensitivity, manipulate their thoracic spine and re-image their brain and some pain sensitivity. We see some changes in their connectivity between their sensory and motor regions in the brain immediately after manipulation, and some changes in sensitivity. And Carol Courtney has done some work in the neck pain with this. And I think that it can be a therapeutic window potentially to help then patients be able to exercise and improve their motor and or sensory pain experience with shoulder pain with manipulation, for example.
Yeah, that's great. Yeah, interesting design. That's awesome.
It sounds so easy. Yeah, a little more complex to how we did all that. But anyway, moving forward.
Yeah. Yeah. Well, Can I talk about, you mentioned dosing earlier, and I did want to touch in on that. So whether we're talking exercise or manual therapy or really any of our interventions, I think it's challenging for many of our practitioners, especially when they're early in practice, to really get a good concept of dosing. Could you maybe describe how you try to guide folks in determining the appropriate dosing? And I'm just wondering, kind of in your experience, if there's areas you think we routinely undertreat, and so, we never really hit a therapeutic dose, or conversely, areas or interventions you think that we overdose or overtreat and maybe just wind up aggravating our patients.
Mm-hmm. 2 or 3 things I'd like to touch upon with dosing. One, we're currently in a clinical trial now, single arm, looking at exercise alone for patients with rotator cuff tendinopathy. We are titrating the dose by using a Borg scale and asking patients, and kind of lifting this a bit from the strength and conditioning literature, if you will, and some other tendinopathy literature, that they should be exercising at a 7 or 8 out of 10 when they're exercising. I don't know that we know the magic number of repetitions, but if I'm having them do a set of 10, by the time they get to the 10th, they feel like they could only do 2 or 3 more, that they are feeling like they're exercising pretty hard, if you will.
Okay.
And so we ask them to rate a Borg rating. And I find that helpful, and even using that now clinically to understand, am I really dosing them appropriately if my goal is to load the tendon and muscle? We used to think with shoulder tendinopathy, like other tendinopathies, maybe eccentrics is the key to life. Maybe we really should be doing eccentrics rather than concentrics. And a couple clinical trials that looked at eccentrics versus concentrics haven't bared out like there's a bigger therapeutic effect from eccentrics. And so maybe it's more loading, and maybe it's the right loading. And how do we determine that right loading with respect to their effort is how we're thinking about this with this Borg scale rating. But the other caveat is there's a really great trial that came out last year at AJSM. Clausen was the last author. Michener is his first name. And it was the SEXY trial. They basically took patients with subacromial pain and randomized them to usual care, which is going to a physio and getting some kind of strengthening stuff and stretching maybe, and maybe pain science. It could have been any kind of thing in there. And then they also got an extra dose of strengthenings. They were randomized to the regular plus extra dose. And their extra dose was a piece of TheraBand. And they did more repetitions, more exercise than their randomized opposite group. And they actually measured those by having a little meter on the band to really understand, are they really doing this extra dosing? Mm-hmm. And they basically saw no difference between groups. It could be a whole host of reasons, which I'll ignore that because I want to go on to the secondary analysis that they now have looked at. Psychological factors, yellow flags, may play a role in also understanding how much we should be dosing people. So if you remember what I had just said, the 2 groups were usual care exercise plus some more exercise. They looked at pain catastrophizing at baseline, and they said, okay, if I split these people into high and low pain catastrophizing, taking the median point and splitting this group, if you had high pain catastrophizing, did you respond better to one of the interventions versus the other? And interestingly, if I had high pain catastrophizing, I actually did a bit better if I had the regular dose. And if I had low pain catastrophizing, I kind of did a bit better with the higher dose. And so basically these things at baseline and or even tracking them over time, which I would argue we really need to do if we think that psychological factors and impairment, and it changes over time as they understand what's happening with their shoulder. If they have pain catastrophizing, maybe dosing them higher induces more pain catastrophizing, and maybe that isn't so good for that patient. When we think about dosing, am I giving them enough load if that's what I want to do? And are there other factors that may impede that higher load from having a beneficial effect to the muscle and tendon because they have an overlay of fear, pain catastrophizing, multiple yellow flags. They might be doing the exercises, but they're getting these negative effects. Does that make sense?
Oh, yeah, definitely. And just to consider that in the overall prescription dosing, maybe those are things that we don't routinely take it to that next level.
Mm-hmm. And one of the clinical trials is trying to sort out the stepped and matched care for patients. So people come in and can respond well to exercise and/or exercise and manual therapy for people with shoulder pain. Probably 20 to 40% of people don't respond well, either have a delayed response or they don't ever respond and they end up after a bout of physical therapy at the same point they started at. They might have got better initially, but they bounce back at the end of care and or 3 months later at the same point they started. And so what are we missing? Is it the dosing, as we talked about? I think that's part of it. And I think the other part is yellow flags, that we are tracking yellow flags over time. And we're starting to see in our early response that it's not just baseline that can help you predict what the outcome would look like if you have more yellow flags or a certain level of yellow flags that you won't do as well. And so understanding, do they need to be addressed in order to benefit from the resisted exercise and or manual therapy?
And that's a good point, and just kind of integrates that idea that the screening for these things isn't just what we do day one and then we forget about it, that those are things we need to track over time with our patients.
Sure. And there's a lot of forms to use and it's kind of overwhelming. Like, how much more things do I need to screen for, Lori? My goodness, like now you're telling me I have to collect all this other stuff. But I think if a patient comes in, you see them the first visit, you don't think there's any indicator they're responding. Maybe at the second or third visit, you may give that to them as a routine thing if you don't feel like you had time on that first visit. And just to kind of do a quick screen like you would with blood pressure. Doesn't seem like you have high blood pressure, but how do I know that you don't have fear avoidance just looking at you? Like I can't tell if you have high blood pressure just looking at someone. And so maybe it's something you do on your second visit. The nice one that I provide a link that you might be able to put in the podcast, that Trevor Lentz wrote an article about screening over time, but it also points to the OSPRO yellow flag screening tool that allows you to screen for 11 underlying constructs of yellow flags. And so it's not 11 forms, it's 17 questions that can pretty well predict what your scores will be on 11 different scales. Fear avoidance, tamponkinesiophobia, self-efficacy with rehab, etc. And that I find from a clinical practice perspective helpful with respect to understanding if there's anything I should be addressing.
Yeah, that's great. We'll put a link to that in the show notes for this episode.
Perfect.
I wonder if we could just finish up. I was wondering if maybe you could just take us through kind of a course of management for what you might see with a typical patient with glenohumeral arthritis, and maybe just what you would prioritize for both the examination and the treatment of a patient like this, maybe just over the first, 6 visits, your early encounters with them.
Mm-hmm. So when they come in and they may or may not have a diagnosis of glenohumeral arthritis, like typically these patients come in with the diagnosis of somebody's told them they have a full thickness rotator cuff tear. Lots of overlap between a full thickness rotator cuff tear and glenohumeral osteoarthritis. They can easily occur in isolation, but they may more frequently occur together. What is the underlying driver of their symptoms? So from the clinical exam in the recent CPG on glenohumeral osteoarthritis and physical therapy journal, some imaging can help to differentiate between rotator cuff full thickness tear and glenohumeral osteoarthritis. But clinically, there's not a good bout of tests that can help differentiate that. And frankly, the treatment may be similar for these patients who come in with or without rotator cuff osteoarthritis together or separately. I may think of them as a very similar treatment approach with respect to what am I going to do with them. People with glenohumeral OA may have additional, and this is from my clinical perspective, not from the evidence, but they may have some clicking and catching that occur with their arm at the side in these internal external rotation. You're moving your arm, or maybe in a 45-degree when you're internally externally rotating your shoulder. They may have some clicking and or catching. We think of these catching and clicking as glenohumeral tear signs sometimes, but they're likely in the younger population and with their arm more in overhead or 90 degrees or above positions, not at the side. So that might be a nice clinical pearl that has not really been fully investigated with respect to differential diagnosis and evidence for a clinical exam. But if above 90 and they're clicking and maybe catching, I'm thinking labral tear. Below 90 degrees, internally, externally, even below 45, I'm thinking glenohumeral osteoarthritis. And age, I'm not thinking OA in younger individuals. However, I have seen people with OA in younger individuals. And again, if they're clicking, catching below this 45, even if they're 45, you should start having index of suspicion of OA.
Great clinical tip.
So, can we differentiate now OA from rotator cuff in the 60-year-old who walks in? Are they both going to have weakness? Yes. Are they both going to have maybe markedly weakness in external rotation? A clinical test for full thickness rotator cuff tear? Yes, probably. Especially if they're having some catching and they can't get their arm out into full external rotation. They may have marked weakness when you test them for resisted external rotation. So that probably isn't going to be helpful. Are they going to have marked weakness in empty can or full can test? Yes. So hard to differentiate from a clinical exam OA from rotator cuff. But here's the good news. You likely don't need to spend a lot of time saying which one is it as a physical therapist. If I'm an orthopedic surgeon, that's a different story. In my physical therapy practice, I am saying, okay, what am I going to do? I want to try to work on strengthening with these people. Is there some evidence to suggest that maybe that can help with centering the humeral head? Not so much. Like, can we really get that head back into the glenoid and really get good depression? Not so much, but maybe it helps with some better coordinated movement as I'm moving. People can improve and or become asymptomatic with OA rotator cuff tears with rehabilitation focused on strengthening and or coordination, motor control type of exercises.
Yeah. And do you generally prioritize maybe closed chain over open chain, or what are your feelings on that?
Oh, so interesting that you asked me that. We did a small clinical trial. We're in the process of publishing that now, where we looked at closed chain for people with full thickness rotator cuff tears. A physical therapist that took a class when I was teaching in Virginia said, have you ever thought about closed chain approach for people with full thickness tears? I'm like, oh, show me what you mean. Oh, like push-ups? I mean, dips? No, these people are older. They can't do that. Are you crazy? And then looking at a regular squat rack, for example, you can have some pegs on either side of the rack and put a band across, so a circular band that stretches all the way across. And now I'm holding onto the top and doing a pull-up, but the band is helping assist me in doing that pull-up, for example. Or I can do a push-up and I'm having some band help assist me. So we describe this in this closed chain approach, but the Kaiser equipment also allows you to do some of this assisted motion and closed chain. And maybe the advantage of closed chain is you're doing it bilaterally and you're getting more central nervous system input and or overflow from training the other shoulder to the shoulder that is having difficulty. I mean, mechanistically, we looked at EMG and saw doing a similar exercise in an open chain versus a closed chain. The closed chain induces more muscle activity than its counterpart in the open chain. We matched for body weight and effort, etc. But the EMG bears out that maybe it's inducing more muscle activity. I think there's likely some proprioceptive benefits, maybe with also more co-contraction. We didn't investigate this, but theoretically, it may be that it's also helping for better stabilization of the humeral head. Also, in even patients with rotator cuff tendinopathy that are younger, they're advancing to these closed chain exercises. And maybe we should be starting them with closed chain early on, just from the first treatment as well. There's an article that I'm happy to provide a link if people want to see the closed chain exercises. We published the paper about that and the EMG evidence.
Yeah, that would be great. We can put that in the show notes as well.
I should say the other piece of the treatment, we've talked a lot about strengthening and how we do that. Open chain, closed chain, dosing, even with these patients with arthritis, dosing enough that you're trying to load the muscle enough. And then is there impairments related to mobility that's not allowing them to fully get their arm in positions they need, and also strengthening into that range? So I'd also be thinking about self-managed stretching or soft tissue mobilization, manipulation, spinal manipulation, mobilization, and the effects we've talked about before as additional interventions beyond just the strengthening would also be key components to the treatment approach for patients with glenohumeral osteoarthritis.
That's great. Thank you for sharing those insights. Both from the literature and from your clinical experience as well. I've really appreciated you joining us for today. Before we go, though, I thought maybe I'd ask: is there any maybe final thought or key takeaway that you'd like our listeners to remember most when they're looking at either evaluating or treating shoulder disorders?
The key takeaway is measure those impairments, strength, range of motion, etc. Use those as measures to understand what should my treatment approach look like. But the ultimate outcome the patients care most about is their function. So I can't emphasize enough, you have to be using outcome measures. And in my practice, it's triangulating information. I'm asking the patient on a generic legacy scale, like the DASH or the Penn shoulder score. Here's 20 activities. Tell me how much difficulty you're having. And it helps to guide my assessment, or even on that first visit when I see the activities that are giving the most difficulty. But sometimes the activities that matter most to them are not necessarily on a legacy standard questionnaire. So the second one I always ask is patient-specific functional scale. That really helps me guide what I reassess in the patient with respect to maybe some activities, actually having them do that and see how much pain, so a more movement-evoked pain kind of assessment in the clinic based on those patient-specific activities. And I think that builds great therapeutic alliance. Oh, look, she's asking me what's most important to me, and she's telling me this is how she's going to help guide my treatment effectiveness to understand if we're on the right path. And then the last thing I think is important to consider is what's good enough for your patient. So I've asked them the Penn shoulder score and they tell me their function. And then I've asked them the 3 things that are most important to them and they tell me that, and I see that score. But I still want to know, do they want to get to the top of the score on the Penn? Do they want to get to the top of the score on the patient-specific functional scale? Maybe not. They may rate themselves as a 5, but 8's good enough. So 2 ways to think about this. You could ask them, well, where do you want to be on this patient-specific functional scale? Then you understand what your criteria is and what you're moving towards. And or you could ask them patient-acceptable symptom state. If left the way you are today, given your difficulty in moving and your pain, in 6 months from now, would you be satisfied if you were left the way you were today? And I find that particularly helpful as well.
Thank you. That's a great takeaway and final thought for today. Thank you, Lori, for joining us, and thank you to our listeners as well.
Thank you for having me.
This has been a production by the Foundation for Orthopedic Manual Physical Therapy in support of AAOMPT. You can learn more about the Foundation for OMPT, as well as make tax-deductible donations on our website at aaompt.org/foundation. The views and opinions expressed on this podcast do not represent the official positions of the Foundation or AAOMPT. The information provided should not be used for personal health care or clinical expert advice.